Central nervous system case. A long, difficult, very hard case to crack in the exam. No, that's not how it actually is. If you apply bit of knowledge and if you do a bit of smart work, we can compile the entire CNS case into just two sheet. One, as you can see at this sheet, it comprises of basic investigations, primarily HOPA and cranial nerve examination, and the second sheet, which is motor system examination, sensory system examination. And when you look at these two sheets, it feels like, yep, it might be easy, but no, you still have to do a lot of work to cross the line. But this is just a last minute revision tip, so let's go through it. Let's begin with the history taking. Name of the person, age, gender, address. Then we have the occupation, date of admission, date of examination, chief complaints in chronological order. Then we have history of presenting illness. In history of presenting illness, we'll focus on this set of questions wherein it is related to higher mental functions such as altered state of consciousness, onset seizure, any fall, fever, nosebleed, ear pain. Then we have mental state and cognition, memory changes, alert or drowsy, language change, decreased ability for daily living. Others such as speech difficulty, difficulty to recognize inappropriate cry or laughter, lack of interest, delusion or hallucination. Then we'll ask questions related to center nerve dysfunction, such as loss of vision, smell, taste, alteration in facial feeling, double vision, achieving problem, speech alteration, hoarseness of voice, dysphagia, vertigo, hearing problem. Then we'll move on to questions related to motor dysfunction, such as weakness, paralysis or plagia, limbs, was it ipsilateral or contralateral, onset, acute or chronic progression, was it ascending in progression or descending progression, wasting of muscles or loss of bulk. Usually you see a stroke patient with loss of bulk. And then we have stiffness of limbs, gait abnormalities, involuntary movement. Then we'll ask questions related to sensory dysfunction such as numbness, altered feeling, paresthesia or spontaneous pain. Then sensory loss pattern. Then we'll ask questions related to cerebellar dysfunction. Did he had any tremors or swaying, or was there any problem with coordination or any abnormal eye movement? Then we'll ask questions related to meningitis or increased intracranial pressure, that is headache, neck pain, projectile vomit, blurring, photophobia, seizures. Then we'll ask questions related to history suggesting autonomic dysfunction such as skin dryness, palpitation, perspiration, syncope, bladder dysfunction. For examiner's viva perspective, what if the patient had headache? How do you investigate? It's simple: onset, duration, location, unilateral, bilateral, severity, frequency, radiation. Where does the headache radiate to? Does it radiate to shoulder or back? Then types of headache: continuous pulsating, stabbing, sharp, throbbing, dull. Aggravating factor, precipitating factor. Precipitating factor usually includes stress, menses, allergens, decreased sleep, cough, bending. Then related to headache, we'll ask about photophobia, history of head trauma, fever, neck stiffness, caffeine intake, smoking, alcohol history. Then if he had any seizures during that episode, we'll ask about duration of seizures, onset, frequency, injury due to seizure, factors which increase this episode: associated sensory deficit, motor deficit, cognitive deficit, muscle spasm, history of any head trauma or drug history, and effect of seizure on daily activities. Then we'll ask about past history, as usual: asthma, COPD, TB, DM, hypertension, ischemic heart disease, seizure. If it's seizure in detail, as we have mentioned previously, along with the drug use, then family history, three generation pedigree, Then personal history, diet, appetite, sleep, bowel, bladder, habits, smoking index, alcohol, unit or grams per week. Then we'll ask about drug history, frequency and duration. Summarize the positive findings. Then we'll give few differential diagnosis based on your initial HOPI findings. Then we'll move on to general physical examination. So, yeah, so and so, a old male or female patient, moderately built, nourished, conscious, cooperative, well oriented to time place person. Vitals, as usual, we know pulse, BP, respiratory rate. Please make sure you write in detail about pulse, which arm, which artery, rate, rhythm, volume, character, wall thickness, if any radial or radiofemoral delay. Then we'll proceed with pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. We'll calculate BMI. Then we'll move nervous system examination, the part where all of us try to find it difficult. Nervous system examination questions will be basically like which hand was his dominant hand. Higher motor functions will be asked, such as consciousness, orientation to time, place, person. We ask patient generally about what time it is, like is it evening, morning, or night, or is he aware of the day. Then we'll ask questions related to memory, intelligence, mood, speech. Then cranial nerve examination. Cranial nerve examination. First nerve, olfactory nerve, smell. So coffee, pepper. We'll use other things to distinguish smell. Then we have optic nerve, light perception, hand movement, visual field. Then 3, 4, 6, oculomotor, trochlear abducent, eyelid, look for ptosis, eyeball, look for the position, extraocular movement, uniocular, binocular, pupil size, shape, pupil size is important here. Then shape, light reflex, nystagmus. Then fifth, cranial nerve, trigeminal nerve for sensory part, sensation of facial mucosa, buccal mucosa, motor part, clenching teeth, masseter, temporalis are the muscles involved, reflexes, corneal, conjunctival, Georger. Then we'll examine facial nerve, the seventh nerve, sensory test of anterior two-third of tongue, sugar, salt, vinegar. Then motor, wrinkling of forehead, closing eyelid, showing teeth, blowing cheek, whistling, nasolabial fold, and platysmus. Then we'll move on to the eighth cranial nerve, that is vestibulocochlear nerve, cochlear Renes test, Weber's test, vestibular caloric test. Then we go on to ninth and 10th, that is glossopharyngeal nerve and vagus nerve, in which we examine for position of uvula, then movement of uvula, say ask patient to say look for it, look for gag reflex, palatal reflex, test of posterior one-third of the tongue. Then we'll look at the next nerve, spinal accessory nerve, sternocleidomastoid, turn head against resistance, trapezius, shrugging of shoulder against resistance. Then we have hypoglossal nerve, tongue size, look at the vesting of tongue, protrusion, look for any fasciculation. Then deviation, if the tongue is deviated to any side. Then we have tremors of the tongue, palpation, look for tongue tone, power, and speech. And the next part, that is examination of motor system and sensory system. These are the parts which focus examiners viva. These questions are pretty simple, but you need to remember them by thorough revision or repetitive examination over patients. So now let's look at the motor system and sensory system examination in detail. Motor system, bulk, 10 centimeter above, 10 centimeter below Ohlen-Cranon process, 18 centimeter above, 10 centimeter below tibial tuberosity. After you look for bulb, make sure you look on both sides, then compare it. Then we have the tone. Tone is a partial state of contraction of muscles, which you have to look for at either cogwheel rigidity or look for any rigidities. Then we have upper limb and lower limb. Do the tone, then power. Grading of power. Here we have 0 complete paralysis, 1 flicker to eliminate gravity. The After eliminating gravity, there is a movement. Then for grade 3, you can do against gravity but not against resistance. The movement is not possible. Then grade 4, the movement is possible against gravity and against resistance. Grade 5, the normal power. How do you check for power? Basically, you look around the joints because the muscles contract and relax where you can appreciate it. Shoulder flex, extend, abduct, adduct. The joint movement is basic principle for muscle to contract and relax. So we do these joint movements like elbow, wrist, fingers. In lower limb, we do the movements of hip, knee, ankle, and toes as mentioned in the slide below. Then we'll go for next part, that is the reflexes. So the superficial reflexes includes corneal reflex, abdominal reflex, which is further divided into epigastric, mid-abdominal, hypogastric. Then we have cremasteric and anal reflexes. So in deep reflexes, we have jaw jerk, bicep, tricep reflex, then knee jerk, ankle jerk, elbow jerk. As we saw how the power being graded, we have the reflexes being graded too. So 0, no response, that is abnormal. 1 plus slight response. 2 plus brisk response. 3 very brisk. 4 even on slight tapping there is repeating reflex, that is clonus, and it is abnormal. Then we have primitive reflexes, which you basically see in pediatrics, glabellar, tap, suckling, rooting, grasping. Then we have involuntary movements such as chorea, tremor, dystonia, balismus, ethetosis. Then we have coordination, finger, nose, finger, then outstretched hand. Sensory system examination. We have primary sensations such as touch, pain, temperature, vibration, and if the primary sensation is intact, we do cortical sensation. This is 2-point discrimination, tactile localization, figure identification. Then we have Romberg's test. After that, we have gait. Look for gait such as Parkinsonian gait, Walding gait, spastic gait, and even observe for slow, rapid. How was the nature of it? Was there look at the swinging hand and was there any fall to the side? Then cerebellar signs such as limb ataxia. We do tests like outstretched hand test, finger nose test, nose finger nose test, finger test, rapid alternating movements, dysdiadokinesia, such as pronating supination, thigh slapping, tremors. Then in lower limb, we look for heel knee test, foot tapping, in general, nystagmus, tremors, gait. Soft neurologic sign just for your extra marks purpose: pyramidal drift, cerebellar drift, parietal drift. Other system, CVS, per abdomen, RS. Write accordingly whatever you find, then summarize the entire case, then give your diagnosis, probable diagnosis, or even differential diagnosis. So with that, we have completed CNS case in just 10 to 13 minutes. So if you want to quickly revise through this, just take a screenshot and day before exam just go through it, so that you get a quick revision out of it. So this is case sheet 1, wherein it's up to cranial nerve examination, and we have sheet 2, wherein we have included motor system and sensory system. So make sure you do it confidently. Confident is of paramount importance, and that's how we should do it. All the best.